Good afternoon, everyone. Today we'll have a brief discussion about the key graphical representations on a ventilator. So, we know that mechanical ventilation is the method to assist in breathing for the patient, right? We provide respiratory support for patients with conditions like ARDS, COPD, etc. And we use mechanical ventilation to ensure adequate oxygenation and removal of carbon dioxide. Right. So, what is the importance of ventilator graphs? So, primarily we do it for three reasons. One is monitoring, to continuously assess how the patient is responding to mechanical ventilation, and to adjust and optimize ventilator settings as and when needed, and to identify complications such as pneumothorax, wheelie, or patient ventilator dysynchrony. So, what are the types of ventilator graphs? There are primarily three of which we will be discussing about two. These are either waveforms or scalars. These are like if you plot them on a graph, the x-axis will be time and y-axis can be either pressure, volume, or flow waveforms. So these are the three scalars, and then we'll discuss about two of the loop graphs, which are pressure volume and flow volume loops. Trends are available on ventilators, but we will not be discussing about them today. So scalars. So basically, these are pressure, volume, or flow are plotted against time. Right. So x-axis is time, and y can be either of these three: flow, pressure, or volume. So we'll start with pressure waveform. So we are basically plotting pressure against time. So this is a normal pressure curve. This is the idealized one. So you normally don't see this in patients, but this is how it's supposed to be. Pressure is measured on y-axis on centimeters of water, and time on the x-axis. So there is initiation, like there's no pointer. Like where you see inspiration, like suppose the patient is taking 20 breaths per minute, right? So, and IE ratio, you have put it as 1:2. So inspiration is going to be 1 second and expiration is going to be 2 seconds. So when you plot it, when you plot the pressure changes in the tubing against time, you'll see this picture. So the 5 centimeters is the peak you have set in. So this will be the lowest pressure that is be seen on the graph. And at the initiation of the mechanical ventilation, this is when the breath is initiated, you'll see a sharp rise in the pressure, which will we'll get a better picture there. Okay, so you'll see a sharp rise in the pressure, and followed which there will be a gradient, right? It will reach a peak pressure, then you'll see a fall in the pressure, and you'll see a plateau phase, followed and where the plateau phase ends is where the inspiration ends, right? So this is time cycle, means at the end of 1 second, the ventilator will stop giving the breath, and then you'll see a sharp fall in the pressure. This is during the expiratory phase. So in this thing, you see the first part, right, where there is almost a square pattern rise, right, like 90 degrees rise, and you'll see a point noted as break point. So why do you see like sudden sharp increase and then followed by a gradual increase? So this sharp increase is to overcome the airway resistance, right? And you'll see a similar thing at the end of the thing. After the peak pressure, you'll see a sharp fall, right? So that will be equivalent to the initial sharp rise part. This will be the peak, airway resistance pressure, and followed by you'll see a plateau phase. If you do an inspiratory hold, right, the plateau phase will be flat for some time and then slowly start decaying till the end of inspiration, when they will find a sharp fall. That will be, so you'll see the following things here, right? Peak pressure. So the points you notice in the graph are peak pressure, P peaks, plateau pressure, and expiratory pressure, right? These are the three things you'll notice here. So what is the peak pressure? This is like the peak of the highest amount of pressure the ventilator has to apply to give the set tidal volume, right? This peak pressure means matches to the resistance of the airways, right? And you'll always once it reaches once it overcomes the peak pressure, and you'll see a sharp fall, right? This is the gap is the airway resistance part. So P peak is usually airway resistance pressure plus the alveolar compliance pressure. So what is pressure, right? You want to push a certain amount of volume through a tube, right? It could be the tubing connecting to the patient, ET tube, the tracheal tube, or the bronchi, right? So to push it against that, you'll have to do some work, right? So you'll have to apply some pressure to push the set volume of air to the. For the air to reach the alveoli, you need to the amount of pressure that is required to push it is the peak pressure, right? So the common abnormalities we can recognize in pressure time graph are, in the normal graph you can see peak inspiratory pressure, plateau pressures, airway resistance, and time of inspiration. In case of high resistance airway, you'll see a significant increase in the second picture, right? The PIP and P plateau, right? You see a sharp, you see an increase there. That is due to increased airway pressure. High flow, you will notice that the inspiratory time is shorter. So as the flow, like the amount of time it requires to push the, expiration will start in a mechanical ventilator when the expiratory valve opens, right? But if the ventilator has already pushed the required tidal volume, inspiration will end there. So you'll see a sharp inspiratory time is shorter than normal, and in cases of decreased lung compliance, you can see an increase in plateau pressure. So you can both PIP and P plat are increased, but the airway resistance is not changed much, right? So plateau pressure has increased. So in these cases, right, because the compliance has changed, there is nothing obstruction, or there is no obstruction in the airways. Suctioning here will not be useful. But if you see airway resistance has increased, right? Airway resistance can be increased due to either due to kinking of the tubes, or it could be due to accumulation of fluid in the tubings, right? Or bronchospasm. So it could be either of those. So treating those in cases where you see sudden increase of the airway resistance, right? You can treat those conditions, like you can administer bronchodilators or remove the kink or do suctioning, right? It will be useful there. But if the peak inspiratory pressures are elevated, but the alveolar plateau pressures are also increased, right? And there is no difference in the resistance. So in these cases, that means there is no problem in the pathway, tubings. The problem is in the alveolar compliance. So in these cases, doing suctioning will not be really useful. So pressure time curve can also detect inadequate flow when pressure rises very slowly, and sometimes there is a depression in the inspiratory limb of the pressure. So normally you see a sharp rise, right? Normally, like you have seen the graph, initial graph, but here you see a gradually increasing pressures, right? That means there is an inadequate flow there. In case of acute asthma, again, so you will see a massive increased peak inspiratory pressure, but plateau pressure and peak remain unchanged. Remember, this is different from where the compliance has changed. Here, peak, this looks like, again, for the initial high airway resistance picture, right? Pretty much same thing. So the second graph we'll be looking at is the flow time graph, right? So we'll need to identify spontaneous breath, mechanical breath. By looking at the graphs, we should be able to identify the typical flow patterns, inspiratory flow and expiratory flow. Right. So what are the typical flow patterns seen in a graph? It could be a square flow pattern. It could be a descending or a decelerating flow. That means initially flow is around for example, like 3 liters per minute, and it's slowly decreasing to 1 liter per minute. So you'll see a decelerating pattern there. Or you can see an ascending or accelerating pattern where the flow keeps increasing, or you can see a sine wave flow. Spontaneous breath, right? So in a flow time graph, the positive part will be where the flow is towards the patient. Negative flow will be where the flow is away from the patient. So inspiratory flow is traced above the baseline because it is towards the patient. This flow represents a sine wave pattern, right? So flow initially is high, it gradually slows down and reaches a plateau, and then it will slowly, then there will be, when the patient stops breathing, I mean inhaling, you'll see a sharp fall into the negatives because now the flow is coming towards the ventilator. You'll see a gradually increasing flow from here. Again, compared to mechanical breath, the initial pattern will be a square, like the inspiratory pattern will be a square. Because when the patient is spontaneously breathing, the flow will keep changing as the lungs keep getting filled up. But in a when the mechanical ventilator is giving the breath, it will give at the flow required set flow. Again, tracing below the expression, it will the expression is dependent on patient lung characteristics. So a square flow pattern is used throughout this part to identify the inspiratory of mechanical lung. We are looking at the inspiratory components now, right? So this is mechanical ventilator derived breath. So exhalation valve closes and the ventilator will start giving the breath here, right? So the moment ventilator starts giving breath, it will reach its peak inspiratory flow rate, PFR. When the ventilator is giving the breath, it will always be at the peak inspiratory flow, right? And it will go and it will keep delivering that amount till the tidal volume that has been set is delivered. And once the breath is completed, when this thing and exhalation valve opens, you will see again sharp fall. And now because the air is moving away from the lungs of the patient towards the ventilator, you will see a negative graph here. So you can see the inspiratory time. This TI part is the inspiratory time and TE expiratory time. Both TI and plus TE is going to be the total cycle time here for one mechanical breath. So the component of expiratory flow is, you can see the initial peak expiratory flow rate starts at when the expiratory wall of this thing. Because the lungs are full, flow is going to be maximal there. But because it is a passive process, as the lungs size keeps decreasing, the recoil factor decreases, right? So the flow will slowly start decreasing till it reaches zero. So what abnormalities can we recognize in the flow time graph, right? We can look for obstruction versus active expiration, response to bronchodilators. You can look for air trapping and auto-peep generation. So in airway obstruction, right, it could be either due to bronchospasm or accumulation of secretions, you will see a decrease in peak expiratory flow rate. See, the red part is the abnormal part, like the airway obstruction has occurred. The white is where the normal mechanical ventilation is going on. You will see a decrease in peak expiratory flow rate, and the PEFR is the flow is going to take longer time, right? Initially, it reached the end point of the expiration is changed, right? It's delayed. Whereas for active expiration, the peak expiratory flow will be increased and the duration will be decreased, because now the patient is trying to actively exhale here. So he's going to push out the volume faster. Another thing you can see in flow time graph is response to bronchodilators. So once you have given bronchodilators, you will notice that the peak expiratory flow rate will increase and the expiratory time will decrease, right? If it is effective. If you have given bronchodilator and if these changes are not seen, that means the bronchodilator is not effective, right? So what is air trapping or auto-peep? In cases of COPD, etc., what happens is expiratory flow will not reach zero before the next breath is initiated. So what happens is the total amount of air that was inhaled will not be completely exhaled out, and ventilator will start giving another breath into it. So this results in some amount of air being stuck in the alveoli, right? So this could be due to inadequate expiratory time, the respiratory rate is too high, or it could be due to long inspiratory time, or it could be prolonged exhalation due to bronchoconstriction and loss of recoiling force. So higher inspiratory flow or shorter TI allows long. So to prevent this, right, you need to decrease the inspiratory time and increase the expiratory time. You want to give the lungs enough time to exhale all the amount of air that has been given during the inspiration to eliminate auto-peep. This is the last scalar graph, volume versus time graph. So information that can be obtained from a volume time scalar graph will be, you can see the inspiratory tidal volume, You can see the inspiratory phase, expiratory phase, and the inspiratory time. And the abnormalities that you can recognize by looking at the volume time curve are air leak and active exhalation, right? So volume rises as the breath is being delivered. It reaches the peak when the tidal volume has been reached, and you can note the time, inspiratory time, and then expiration. You can see the other side. So main thing you look at with volume time graph is to look for air leaks, right? So the volume will not reach zero during at the end of expiration, right? So that in the graph shows that tidal volume is not reaching zero. That means there is some amount of air that is being lost somewhere, right? So in that case, you'll have to, it will plateau, and you'll have to look for a leak, and amount of leak can be estimated by the gap between the baseline and the end phase. Pressure volume loops. So for the scalars, we were graphing them against time, right? Where time was on the x-axis and y-axis could be either of pressure, flow, or volume. Now, if you are going to graph these against one another, like pressure against volume, right? So you'll get a looping pattern on the ventilator graph, right? So first we'll be looking at the pressure volume loops. So what do pressure volume loops inform us about? They inform about change of patient's lung compliances, presence of air leaks, patient ventilator dysynchrony, and increased work of breathing. They may reveal alveolar overdistension, and they can also help in calculating optimal PEEP for the patient. So these are the basics you should know about the pressure volume loop, the types of breath, differences between spontaneous, assisted, and controlled breaths, functional reserve capacity, and pressure volume loop components. We'll go into these as we discuss them. So pressure volume loop, right? In a spontaneously breathing patient, the inspiratory phase is going to be towards the negative side. X-axis is pressure here. Y-axis is volume, right? So when inhalation is a negative pressure scenario. And you see this is going counterclockwise, right? The third one, spontaneous breathing part. Inspiration goes up, comes back and goes downwards, right? Exhalation, which is the positive. So this is going to be counterclockwise, whereas mechanical and assisted both will be clockwise. So angle, shape, size of the loop will give you the pertinent information. So functional residual capacity and pressure volume loops. So the beginning point of the volume loop is the FRC level, since breath is delivered and at the end expiratory level, right? So functional reserve capacity, you're giving the only volumes you're changing are equivalent to tidal volumes in the patient, right? So the point where you're giving the breath will determine the FRC for the patient, right? So when PEEP is added, the FRC level will increase. You're going to give certain amount of positive end expiratory pressure, means you're increasing the functional residual capacity for the patient. So what are the components of a pressure volume loop? There will be the inspiratory limb and the expiratory limb, right? Inspiration begins at the FRC level and terminates at the preset parameter, right? The volume you have set or the pressure you have set, like pressure control or volume control. Then the tracing will continue during expiration and returns to the functional residual capacity at the end of the evaluation, right? Peak inspiratory pressure and delivered tidal volume can be identified here, right? On the x-axis, the peak point will be the tidal volume, and the pressure axis, the peak point will be the peak inspiratory pressure. So you'll hear about inflection points, right? So what are inflection points? Inflection is basically on a graph, right? When you're drawing on a graph, if you see sudden change, abrupt change in the graphical representation, that is called an inflection point, right? So here you can see two inflection points, the lower and upper inflection points, right? So during inspiration, you see a lower inflection point. During exhalation, you see an upper inflection point. Basically, you say lower and upper because of the pressures at which you're noting them. So lower inflection point will indicate the opening pressure, where alveoli will start opening. So for the amount of pressure, as the pressure keeps increasing, the volume will increase very slowly. But at certain point, the volume will start showing an abrupt increase in volume. That means this is where alveolar recruitment has started. The upper inflection point will be where de-recruitment is occurring, right? So higher the opening pressure, the stiffer the lung. So lower inflection point, you can is same thing as the opening pressure, right? So higher the opening point, the stiffer the lung, and curve will move laterally towards the right along the pressure axis. So setting a PEEP level at the level of lower inflection point is recommended to optimize alveolar recruitment and prevent repeated opening. So decrease the work of breathing. And repeated opening and closure of alveoli can cause volume-induced lung injury. So ventilator-induced lung injury. So you need to set your PEEP at lower inflection point. So pressure volume loop also will provide a quick assessment of the elastic as well as resistive work of breathing. Work of breathing is area under curve. So pressure into volume, right? So the shaded area is light elastic work, respiratory expiratory work, and the respiratory inspiratory work. The pink is respiratory inspiratory work. If anything that is increases the convexity of the inspiratory curve, right? So or anything pushing the whole loop to the right will increase the work of breathing. So if you see the inspiratory part which has been slightly, it becomes more convex, or the entire graph has moved more towards the pressure, more towards the right, that means work of breathing has increased. You can also notice decreased lung compliance in the pressure volume loops. Shift of the curve to the right in pressure volume indicates decreased lung compliance, and to the left means increased compliance. So lung compliance changes graphically represented, right? In these are two modes, either volume control mode or pressure control mode. Because in volume control mode, the set volume, the amount of tidal volume that has to be delivered is set. So in case of there is compliance has decreased, you'll see that the graph moves towards the right. If that means you need more pressure to deliver the same amount of energy. And if it moves towards the left, that means compliance has increased. And again, for in pressure control mode, peak inspiratory pressure is set. So tidal volumes can vary. So if lung is more compliant, more tidal volume will be delivered. So you'll see a rise here. And if it is restrictive lung disease, you'll see decreased tidal volumes that are being delivered for the same pressures. You can also detect increased airway resistance using pressure volume loops. Patient with obstructive disorders exhibit a wide pressure volume loop. The width has increased in the loop. And area under this thing will naturally increase because of that. So work of breathing has increased. And abnormal widening of the shape of the PV loop is referred to as increase in hysteresis. Alveolar over-distension, right? So this is one of the important points, right? We look for the beak effect at the end of the inspiratory phase. You see sudden beaking sign there. That means there is an increase in airway pressure without any appreciable changes in the volume that is being delivered. Up to the beaking, where it's marked as beaking, right? From here till here, the volume delivered has increased very little, but the pressure has increased a lot. So this means there is alveolar over-distension. This is indication that there can be patient can have alveolar rupture at this point, right? This is known as beaking effect or duckbill effect. So in when you see this, that means you need to, if it is a pressure control, you need to decrease the set peak pressures. You can also identify air leaks due to the pressure volume loop. The volume parameter will fail to reach 0. That means there is a leak in the circuit, and this distance will be the amount of leak that is occurring. This is patient. This is a PV loop for a patient with ventilated dysynchrony. This part is where patient initiates breath, right? And you can see when the breath is going on, patient is trying to inhale it when the mechanical ventilator is delivering the breath. You'll see a curve here. A scooped out airway respiratory curve will experience flow starvation, right? And patient tries to exhale here against a closed loop, right? This is. So last loop we'll be discussing about is flow volume loop. So in the flow volume loop, things we can find out are peak inspiratory flow rate, peak expiratory flow rate, tidal volume, and we can identify where the expiration ends and beginning of inspiration. Sorry. We should go in the presentation. And what are the abnormalities that we can recognize through these loops? We can look for air. We can find out air leaks. We can find out air peep, auto peep and trapping of air. We can diagnose increased airway resistance, and we can diagnose airway secretions and accumulation of condensate in the tubings. So air leak, right? Flow during the inspiration, you see a sharp rise and reach the end inspiration, and the expiratory part will not reach the functional residual capacity, right? Where the volume does not return to the functional residual capacity. Deficit in the volume will, can measure, indicates the amount of air leak. And there the volume has not reached, right? Here you can see that the flow has not reached zero, right? Air trapping autopeep where flow does not return to zero. So next inspiration will begin from here, and so tracing will jump abruptly. So some amount of air is going to be trapped here. And during increased airway resistance, you'll note that flow volume scooped out pattern and decrease in peak expiratory flow rate. So delivering an effective administration bronchodilator will show an improvement in the configuration. And if the scooped out part is still continuously present, that means the bronchodilator is ineffective, right? And if there are airway secretions and accumulation of condensate in the tubing, you'll see this sharp tooth, sawtooth pattern during the expiratory limb. And if you see this sawtooth shape, that means there is some amount of accumulation of fluid in the collection piping or pipings. So either suction or changing the tubing will be useful here. If you do not correct it, you'll start seeing these sawtooth changes even during the inspiratory phase.